Okay, we are going to record. So welcome to the health literacy training today. This is the Wayne County Health Catalyst for COVID care. I'm Dr. Custer, and this is my co-presenter, Maya. Maya will do introductions in just a second. While we wait for others to join, I will go ahead and put up our pre-session evaluation slide. If you could, we would appreciate if you could either scan this QR code or click the link in the chat box that Maya's provided and complete the pre-session evaluation. So we'll give it about 3 to 5 minutes for everyone to have some time to do this, as well as wait for a few more people to join. So I'm going to pause recording and we'll go ahead and not play. Okay, while people are finishing up, we'll just go ahead and get started. It is totally not mandatory, but if you do have a camera and you'd like to put it on, it does make engagement a little easier. You know, we're like three years into this, so we're pretty used to, you know, being virtual, but if you'd like to, please go ahead and put that on. I know a lot of people's computers don't have webcams, so that's a whole nother issue. Okay, so welcome everyone officially. I'm Dr. Carolyn Custer. I have no conflicts to disclose. I am the person who put together this training and working with Authority Health on providing the health literacy component. I'll turn it over to Maya.
Hello, my name is Maya Campbell. I am with Mishwa and I am a proud community health worker. So welcome everyone.
Thanks, Maya. All right, so the agenda for today, we'll do an overview of health literacy. We'll talk about 5 specific interventions that can increase health literacy. We'll take a short break and then we'll come back and talk specifically about vaccine hesitancy and COVID-19. And if we have time, we'll do a quick interactive case discussion at the end. By the end of this, what we're looking for you to learn is, describing health literacy as a determinant of health, identifying strategies to address health literacy. Specifically, we'll talk about class, cultural and linguistically appropriate services, and strategies for culturally competent care. And then at the end, talk about causes of and strategies to overcome vaccine hesitancy. All right, so we're going to start this discussion with a brief review of health equity. I always say it's impossible to talk about health literacy without talking about health equity. Has anyone seen this? Oh, we have a lot of chat. Okay, thanks, Maya. Has anyone seen this image before? This game with the boxes? Okay, so. Okay.
Yes.
Thank you. Most people recognize this. This was an image used to demonstrate the difference between equality and equity. So equality on the left, everyone gets the same thing. So, they each get a box of the same size. Equity is really giving people what they need to succeed. So it may look different for everyone, right? So you see the different height of the boy, they get different boxes. But we're going to take it a step past this, and we're going to talk about a concept of justice. So here's the same image, right? Equality showing that, equity. But what about justice? So what if we go past that and we talk about removing inequities and that are causing these problems in the first place, right? So in this case, you can see they removed the wood fence and they put in a fence so everyone can enjoy that particular game. So we want to think about in the context of systems, in the context of things that were set up systemically, and removing those barriers and pieces of those systems so that we all can get healthy and well-being and whatnot. So social determinants of health kind of go along with that. If you haven't ever learned about social determinants, I'd encourage you to look further. These are the things that impact health that we don't necessarily talk about with our doctor or our provider at the office, right? our health is maybe 20% clinical care, and then the rest of it is really our environment and what we do with our bodies and where we're at. Social determinants are kind of things that exist where you live, right? Where you work, live, and play, that can either that can impact the ability to have health and be healthy. So things like safe neighborhoods to exercise, access to healthy food, even being able to navigate healthcare system navigation, that's very complex. So these are just some of the things that we'll talk about, and health literacy falls into this and is one of these social determinants. All right, Maya.
Yes, thank you so much. So health disparities. So the CDC defines health disparities as preventable differences in the burden of disease, injury, violence, or opportunity to achieve optimal health that are experienced by a socially disadvantaged population. So this exists because health inequities and factors like the social determinants of health and systems designed with structural racism. Okay, so health literacy in Wayne County. So I think we forgot to mention this is a little bit of an interactive training. So we may ask participants to come off mute and share their thoughts, their opinions. So redlining, has anyone ever heard of redlining or familiar with that term that wants to come off mute and just give us a definition of that?
Redlining was a practice that was done in 1939, I believe, that stated what kinds of people could live where based on race, income, language spoken, religion, and essentially like if the land itself was, I guess, entirely safe to live and build on. I think those were all the factors that went into it.
Okay, great. Thank you, Jennifer.
I appreciate what Jennifer said, but if you talk to people today about what redlining is, I don't know if there's anything positive that really comes out of it, in that it segments particularly people of color, Black people, specifically in terms of all kinds of practices, whether it be insurance, where to build or where to provide services. It's like a certain area or zip code is blocked off because of certain infallible data. Like if you're not educated, or it's just, as much as going far as where to put a grocery store, like people eat, but because there's at a certain education level, a grocery store wasn't put in that particular community. That's been, so I just want to just raise that, because we talk today, people don't define it like that. Everybody knows about what redlining is because they've been experienced it a lot.
Thank you so
yes,
very
right,
much.
yeah.
Yes, thank you both, Pancella and Jennifer. And that's exactly right. Populations were cut off from, or they had limited access to things like healthcare, education, as Pancella pointed out, things like grocery stores. So yes, and Jennifer mentioned in the chat that it's definitely not a positive thing, and it was a really bad practice. So thank you both for sharing. Okay. So what does health literacy mean? So what is health literacy? Does anyone want to come off mute and share what they feel that the definition of health literacy is? We know what health is and we know what literacy is, but what is health literacy?
I'm not going to do all the talking.
Come on, Pancella, that's fine.
I'm going to take a shot at it because I know we throw it around a lot. I think it's just a person's ability to, I don't know, I don't want to say the health system, but understand how they interact with all things related to health, whether it's public health or systems is one. And then health literacy, oh, wow, that's a hard one. So, I can name a number of things, but I think health literacy is still kind of in my mind, it means, being able to go to the doctor and understand what's being done to you and what's being said to you. And therefore can respond because you understand what's being done and said to you.
Absolutely, absolutely. And thank you again, Pansela. That's absolutely right. And there's many layers to health literacy, so we'll get into it a little bit more in the training. But yes, the ability to understand, and it's not just on the burden is not just on the patient. Some of the responsibility also falls on the providers as well. So, Dr. Custer, do you want to talk about Healthy People 2030?
Sure. So, every 10 years we put out healthy people goals, right? So things that we can work towards as a nation to become a healthier nation. And, traditionally personal health literacy has been included 2010, 2020, but in 2030, they added organizational health literacy. So just what Maya was saying, in the past, it was always like, okay, we need to improve the patient or members. I'm saying members now instead of patients, but just as a brief aside, patient, consumer, client, member, all the same kind of person. But how much are we doing? It's not just the onus doesn't fall on our patients. The onus falls on us as well to make sure that we're equitably enabling people to understand things. So that's what we're going to talk about today is some of the ways that we can improve organizational health literacy.
Thank you so much. So some health literacy components. So the skills and knowledge needed to interpret health information. So what is literacy? Literacy is just simply the reading and writing basic math, speech, and comprehension skills. And also numeracy. So that's understanding how math is used in the real world. And factors that impact health literacy. The complexity of the health information being communicated. Is it difficult for the patient to understand that? Is there a language barrier? The age of the patient and the state of the health of the patient during the appointments. Are they anxious or sick? Cultural background as well, and the way the information is communicated by the provider. These are all factors that, again, impact health literacy. So this is just a graphic of the previous slide. So it breaks it down even further. So there are individual health factors, and then there are system factors. So the literacy skills, health knowledge, demographics, culture, and experience, those are individual factors. On the system or professional factors, the public health practice, the public health infrastructure, and the public health workforce. These things all together make up health literacy.
Okay, so some of the impacts of limited health literacy. So, if you're not able to understand or utilize health information, you may be less likely to obtain preventive screenings, right? Like our pap smear, breast cancer, mammograms, vaccines. May be less likely to effectively manage chronic disease, right? You have to have some knowledge of the health condition to manage chronic disease. More likely to have poor medication adherence, higher rates of hospitalization and ER usage versus primary care, higher mortality rates, and report a sense of shame about their health literacy. And we'll talk about some red flags and what that looks like in communication. And of course, limited health literacies, all of these are associated with higher healthcare costs and expenses. So what does that look like on a community level? If there's a low health literacy on a community level, they may have missed opportunities for services like screenings. We do a lot of health fairs in Detroit. I think we're good at this. Maybe a lack of preparation for emergencies like a weather evacuation. Missed warnings about, environmental safety stuff like contaminated water or food safety, for example. So it's really important that we work and do what we can to improve health literacy on an individual and on a community level. Health literacy and literacy, how do they relate? So the average reading level of adults in the United States is 8th to 9th grade, but most health education materials are written at like a 10th grade level or higher. So you can see there's a problem there. So they do recommend the quote best reading level for materials is about the 5th, 6th grade. And there is a way to check, the reading level of materials using Word. There's like I don't know the actual tool, I'm sorry, I'm not good at Word, but a way to check the reading level. All right, red flag behaviors, again, if you're in with one of your members and you're noticing some of these behaviors, these could be, caution, red flags that they may not be fully understanding the information. Persons that maybe frequently miss appointments, or excuse me, don't follow through. Incomplete registration forms is a sign. Non-compliance with medication or not being able to properly name medications. Unable to give coherent sequential history. And then the biggest, I think, is asking fewer questions. So like we said on the other slide, report a sense of shame about their health literacy. You may have a client who you're explaining something to, like maybe it's a new treatment plan or something to follow education. And, you know, they're just nodding their head and they're not asking any questions. And then you say at the end, you know, do you understand everything? And they say yes. That can be a red flag, right? Did that person really understand what you were saying? So just to be aware of these things that could present. So health literacy. So we know that, you know, there's an issue with health literacy in the United States. So how are we going to attack it, right? So we're going to use a universal precautions approach. And a universal precautions approach comes from the AHRQ. They have a great health literacy toolkit, and the links to it are all at the end of these slides, and you will get the slides. So what does that mean? If we think about bloodborne pathogens in medicine, and I hope someone in the audience has heard of this before, you know, with HIV and hepatitis and whatnot, bloodborne pathogens, that's what we call them. So you can't look at a person and tell if they have HIV or not, right? So therefore, every single time we have blood spillage or a needle stick or anything like that, we use precautions. We use universal precautions, meaning every single time we see blood, we treat it like it has HIV. Doesn't matter that the patient does, or, you know, whatever they look like. No, we just treat it as it is. It's safer that way. So in the same sense, you cannot assume what a person looks like, I mean, what their level of health literacy is just by looking at them, what job they have, even what education they have. It does not necessarily translate. So if you take a universal precautions approach, you know, you just kind of assume that everyone has a difficulty in comprehending health information. And what it does is it forces us to think about how we deliver, how we communicate. And really the goals of this approach is to simplify the communication every single time, right? Reduce that risk of miscommunication, make the healthcare system easier to navigate, and support our patients' efforts. So I encourage all of you to take what you learned today or what you know about health literacy and just begin to practice and do this all the time. Make it a universal thing. The more we normalize, the less we stigmatize in general. This is the last intro slide. So this is what a health literate organization kind of looks like. We're not going to go through each spoke of this wheel, but you can see here that, you know, the priority has to come from the top, right? So leadership all the way down to your end users, which are your members and your patients. And just looking at how, you know, you have to consider health literacy in every operation planning, etc., to be able to deliver really good care. So that's kind of what our goal is, to become health literate organizations. All right, I'm going to turn it back over. Oh, I'm turning it back over to Maya.
Thank you. Okay, so we have another interactive slide. Would anyone like to share a time when low health literacy impacted a loved one and their ability to be healthy?
Sorry, say that one more time. So you want us to answer that question?
Yeah, do you have an
Let's see.
experience that you'd like to share where a loved one was impacted by low health literacy?
I can probably use myself as that. I don't know if this is correct or not, but I remember going to the doctor, and I changed to a female doctor for, you know, a lot of different reasons. And I felt insulted because I had a condition on my neck, and I kept going for the same thing, and she kept giving me the cream, and I just felt like, okay, and when I felt like I know something else is wrong, but I just kept letting her give me the same doggone cream every time. So I don't know. So I just felt like, so instead of there was an instinct that I wasn't getting the kind of attention that I needed. And it was a diagnosis that was given to me that I didn't agree with. So I just left and changed doctor to another doctor. And he said he didn't find what I was diagnosed with, which as being true or whatever. But I didn't know really how to, that's one way. And then, yeah, I think that's one way. I don't know if that's health literacy or not, but not understanding how to respond to her when I felt in my gut, it wasn't, I didn't feel, he wasn't hearing what I was saying, what was going on with me.
Absolutely. Thank you so much for sharing. And that is absolutely a great example of health literacy and how it impacts our level of care. So I think of patients as my time as a CHW that had probably the same questions or the same concerns as you, Pansela. They'd come for a few appointments and we'd not see them again for long periods of time. So yes, that definitely impacts health literacy. And Angela, I saw that you came off mute. Did you have a comment?
Yeah, I just wanted to share a personal experience of my mom. She got the blood pressure cuff to measure her blood pressure. And, she kept saying, it was high. And I said, what did they tell you? What was the number you're supposed to be in a normal range? And she could not tell me. So we printed out a little chart for her. So yeah, she could not tell me. How do you know it's high if you don't even know what range you're supposed to be at, So I and they probably told her, but she, yeah, I thought that was interesting, especially because she doesn't speak English. So there was a barrier there too.
Oh, that's a great example as well. Thank you so much, Angela. And yes, you're right. Having a home blood pressure cuff is amazing, but if you're not knowledgeable or if the communication barrier is broken down where the patient or the member doesn't understand what a normal range is, how helpful is having that blood pressure cuff? So yes, thank you. Very, very good examples. Thank you. Okay. Okay, so health literacy interventions. So these are evidence-based interventions and strategies. I'm sorry, give me just a second. I need to shut my window. It's really noisy.
No problem. Okay, so Maya's going to start us off with the 5 health literacy interventions. And these can be used to create a health literate environment, which is our goal.
Thank you so much, Dr. Custer. I'm so sorry that happened.
Okay, you ready?
Okay, yeah, yes. Okay, so health literacy strategy number 1, clear communication. So greeting the patient warmly when they walk into the office, using the patient's own words when communicating with them. We'll give some examples of that later in the training. Showing graphics. I'm very much a visual learner, so showing graphics is very helpful. Making eye contact, slowing down, demonstrate how to do something. For example, demonstrating how to use that blood pressure cuff or how to use that thermometer. Listen carefully, limit and repeat the content, invite the patient's participation, use plain non-medical language, be specific and concrete, and encourage the patient to ask questions. Okay, so 7 things to consider when communicating about health. So the first one is trust. Will the person trust the information that's being communicated? And who is the best source to put that information out? Is the best source the community health worker, or is the best source the provider? Information is number 2. What information is necessary and how will people find it? How much is too much? Because information overload is definitely a thing. Number 3 is the motivation. So how relevant is the information to the person that you're trying to reach? Do you want me to continue, Dr. Custer? I always feel like I just take this slide. Okay, so environment is number 4. What are the conditions that surround and affect the audience? Number 5 is capacity. What is the person's ability to act on the information? Are there barriers? 6 is perception. What will the audience think about the information and what will inspire them to act on it? And the final is 7, response. How will the person respond? And what can we do to stay engaged with the patient? Thank you. I'll pass it. I believe I pass it back over to you.
Okay, thanks, Maya. So those are some good tips to think about communicating. Plain language, using plain language is always preferred over medical jargon, as we call it. So here's just some examples of, instead of using things like fracture, broken bone. I always bring this up. The one thing is, if you ask someone, what is your diet? A lot of times they think of Weight Watchers or Atkins or, some sort of fad diet, when actually what you're asking is, what do you eat every day, right? So that can be confusing. Even a word like adverse, can be confusing. It's better to use the word bad. So always think about that. I know community health workers do a great job with communication and whatnot. We just need to remind our, I'm just kidding, our docs to break it down a little more. But we can all contribute to being part of this care team that, increases health literacy.
I'm sorry, I use bad. I use adverse, but I felt like bad was sort of a shaming thing. So I just said, well, maybe adverse is better, but I feel like bad could be a negative thing where it's sort of a shaming. So that was hard.
That's a really good point, Pansela. We do have to be careful about our word choice. And the next slide, we'll go through that. I put that adverse specifically out there because I know that's one that's tricky for people. But that's what's recommended by AHRQ.
Okay, thanks.
But you have to be careful to use the word bad. You're absolutely
Yeah,
right.
especially the person who's using it, who's saying it, that might be another added layer of trauma too.
Exactly. And that's, at the end of the day, that's what communication is all about, figuring out what language your members using and, matching that and using terms that will work. Okay, so the next slide, your COVID test is positive. So when we were doing screenings for COVID, there was one fair that I was at, and the person tested positive. So we said, your COVID test is positive. And they were like, oh, great, right? Because positive is a good thing, just like bad is a bad thing, right? So we ended up having to change the way we were presenting the results. We said, you have COVID or you do not have COVID. And that's fine, right? You tweak your communication to what you need to, but just keep in mind, sometimes even a word like positive can be tricky. All right, so we're going to move on to the next strategy. If anyone has any questions in between, please feel free to pop them in the chat box, or you can come off mute and go ahead and ask. Okay, so let's talk about health education materials. We communicate good, but we also need to make sure that we're using good materials. So like we just said, materials are easy to read and understand. And I don't know who put it in the chat box, but thank you. It is the spell check in Word that you use. And at the end of it, it shows the Fleischer Kincaid, I think it is, reading score. So aim for a 5th to 6th grade, like we talked about. In order to be effective, a handout really has to be clear, right? We don't want to have a ton of irrelevant information. We just really want to have the purpose clearly defined. Using common everyday language, again, like we just talked about, avoiding medical terms. If you have a flyer or material that's just words, all words, it's probably too much for someone. It's very overwhelming, right? To see a handout that has just nothing but words. It is recommended to kind of break it up with either pictures or diagrams or whatnot, make it in chunks of information that are easier to understand. A good material identifies at least one action item, uses visual aids effectively, and is be aware of confusing numbers. So we're going to make it a little fun now. If anyone would like to come off mute and participate, we're going to do some material evaluations. So let's start with these 3 flyers. And if you're on your phone, I apologize because it's going to be small. So there's 3 flyers here. This one's MDHHS. The one on the right is CDC, and the one in the middle is Authority Health. And they all have similar topic. They're all regarding vaccinating children and school-age kids. If anyone, Angela, you came off mute. Do you want to provide any feedback? Which one would be the most effective?
I defer the middle one because it's more clear and it stands out and you could easily read it. And you could keep your cup safe. I
Yeah,
mean, yeah, the CDC one, can't read. Hard to read, a lot of reading. I don't want to read all that.
Yeah.
great.
See, the problem is I like the first one. It just didn't have all the information for me to call. It was like, okay, I might not have a computer. It didn't have the numbers but I was drawn to the colors in the pictures of the people a little bit more. Yeah, CDC, that's probably that's pretty not exciting.
Mhm.
That's my
Uh,
exact opinion, I swear. I like looking at the first one, but the second one has the information that I need. I don't want to read all that on the CDC.
Thank you for that. That's great. Any other opinions? I think you're all right on, right? I mean, this is a very clear message. Keep your cubs safe. Most parents are like, yeah, we know, what keeping our kids safe means. Keep the school year fun going. Yeah, these are nice bright colors and the pictures of kids are having fun, but it doesn't really have any clear message of action, right? I mean, I guess keep up to date. In the COVID one, there's a lot of words. So you guys everyone can see the kind of difference between these. We're gonna move on. Thanks, Maya.
yes.
Okay, so the next one, this one was released by MDHHS kind of in the beginning. And so I want to know what you think about this flyer. So scientists have taken hundreds of steps. There's a picture here, right? And then we have this description that's kind of developed by a proven process, decades of research, months of clinical development, diverse volunteers, clinical trials. Would this be effective to convince your population?
You weren't even convincing reading it, so.
I guess that's my bias against this.
I feel like it's got a sweet message, but it's not really going to be like what pulls in people in Wayne County, realistically. Also, I really dislike the ellipses after COVID-19 in the middle of the sentence. That doesn't speak to all generations.
Oh, this?
Yeah.
The dot.
Yeah.
Yeah, I
What
don't
does that
like,
mean?
yeah, right. I don't like scientists and children in the same picture.
That's valid.
Huh?
Okay, so maybe they missed the mark a little bit on this. This one was funny because it was translated to every language, and I was like, I don't know about that. Okay, let's keep going. So I'm going to show you a couple that MDHHS released. So the first one is the Omicron, bivalent booster. And the reason why I'm showing you this one is it has two different asterisks, right? So we have asterisks, different ones, and then we have small print. And so what happens is this clear or does this create confusion?
It's way too much information. It's way too much. It's too much.
Yeah.
Ooh, I don't even know half of what it means. I don't even.
So I end up being asked to make a lot of the flyers for our stuff like this within our health department. And this is one of my biggest beefs, is because like they say, well, because it's medical information, it's got have to have all the things. And I'm like, but it's so tiny. It's not clear what you're talking about. There's too many asterisks. Like, can we just put in a hyperlink to the information if people want to go to the specific information,
I think that's a great idea.
And I feel sorry for the young lady who's on here because she's all happy, but the slide is not, it's not really, I don't know what she's happy about because the slide is definitely not a happy slide. So,
Yeah.
a picture.
Yeah. Jennifer? Is that a clap or is that a hand up?
It was a clap.
Okay, I wasn't sure. I don't know the other. Maya. Okay, that's great feedback. Let's go to the next one. All I can say is this one's It doesn't still cause me pain, but lots of confusion about this one. Again, we have different asterisks, we have small print. I think everyone just forgot to read. I don't know. So for example, I had a girlfriend call and she said, my daughter has COVID. It's day 6. She's still has a fever, and she's coughing, but her boss wants her to come back and work with a mask. And that happened to a lot of people. I don't know about if anyone else had experiences with confusion about when to go back to work if you have COVID. But it's just an example of, you know, COVID's new, right? It was new. We had to kind of work with what we knew and what we found out. But again, just examples of messaging. And then this last one, make a COVID-19 plan. You know, they have these big fonts that are, and they have a little, you know, visual. The big fonts are good action items. What does everyone think? Any thoughts about all this small print?
Well, okay, now full disclosure, I slapped this on everything. I actually found this slide and I put it in materials. I put it on big walls in the theater. I use this one quite a bit because I thought it was make a plan, but I don't know how effective it was. But I thought it was really clear about the top, you know, the bold issue, the bold point that got your attention. So
Yeah, I'm not judging if people use it or not. I'm just curious of what you think of it.
I like it as a handout, and I like it as a very, very large poster so that you can like look at the parts that you're trying to see, and like it's got the headline, and if you want to look at the more details for the specific headline, you can, but it's not one that you're going to stand there and take all the time to read it all. So it has to be a handout or something you pass by frequently.
exactly. Thank you for validating me. So that's what I did.
Absolutely. You know, in other discussions, people have said just remove the small print, make it those 4 big points. But yeah, there's different ways to look at things, right? All right, so effective messaging has it's a clear message and it's an action item. And I think that's all I got right now. And I'm going to turn it over to Maya for the next 2.
Thank you. Okay, so this is a flyer that was created by MDHHS. So right off the bat, if we consider our population served, what are our feelings about this flyer? If you're sitting in a doctor's office, a pediatrician's office, with a child, how would you feel about this flyer? It's a little scary. There's a person in a bed, person in a hospital bed. There's a cute little baby. She's crying. Something's hurting her. What are our feelings about this flyer?
Again, I interact with these flyers a lot, and I have strong feelings. I don't like a lot of the Missy stuff that's been put out because it doesn't really explain what's really happening. You know, like it's not actually explaining what the inflammation of these organs does, and like it's just like being like, oh well, your organs are a little swollen, but like it's such a cascading effect of what that actually means to the child. And I feel like they don't really clarify what that means. Like, yeah, they say there's long-term like symptoms that happen, but okay, yeah, what are they, you know?
Sure. Thank you so much for that. Yeah, and considering that what we've learned so far just in this training, some of the words on this document or this flyer are kind of big. Prevent multi-system, and that's, you know, considering that, you know, what we know about literacy, that may be difficult for some of our population served to read and to understand. And there's a lot of text here. There is a lot of information on this flyer. Okay, any other thoughts before we move to the next one?
Yeah, I think that there are 2 things that I know it's a lot of work. Yeah, the first thing I look at is multi-system inflammatory. I don't even know what that is, but I do think that there is an issue, and it could be in any level. The issue is that we're being bombarded with so much information like, you know, outside before we get to the doctor, so much information is coming at us so quickly. And then by the time we get to the office and we see something like this, because sometimes you're bored and sometimes you just sit there and read stuff because you're waiting for a long time, but you can't even understand half of it. But I think a lot of people are just bombarded by so much information. Then to come to the office and see this again, this is caused a lot of anxiety, I think. When you have children right there with you too, it's like it's just adding to the trauma a little bit here.
Yes, absolutely. Absolutely. Thank you for that. Okay, so we'll move on to the next one. All right. So this is a flyer that was created by the CDC. So how do we feel about this one? There's no crying babies on this picture or on this flyer. There's some little animations here. How do we feel about this one compared to the last one? Right, yikes. It's a lot. There are a lot of words here, absolutely.
I feel like some of these have their uses, but they have to be with conversation. And you have to explain what the words mean, and that takes time. You can't just hand people these papers. And I feel like that's what's happening.
Sure, sure. Yeah, and we'll get into it a little bit later in the training. But as a community health worker, sometimes these are the only tools that we have in our, in our toolbox. So we have to make do on them. But we'll discuss it a little bit more later. The last two flyers were actually the same. So they had the same information. I think it was important for us to show these two to show the difference between the CDC and MDHHS's information. Both flyers have very important information, but it's just a lot of information. And considering, again, our population served, it may be information overload, and it may be difficult for some of our population or some of our members or patients to understand. All right. All right, so using health materials. So when using health materials, don't assume that your patients can read the materials. And when reviewing a handout, circle or highlight the information that's most important. As I mentioned, fortunately, but unfortunately, as a CHW, sometimes the tools that we have are just what we have. So instead of just giving a patient a handout with all that information, circle and highlight what's important. Personalize that information by adding their name or medications. Use TeachBack to confirm understanding. We'll dive into TeachBack here very soon, and emphasize the importance of the patient keeping the material so they can refer back to it at a later time. And we also want to make sure when referring patients to digital materials that they have access to the internet. Okay.
There's one more, Maya.
Oh, I'm sorry. And obtain the patient's feedback on materials. So that does help improve the materials moving forward, just getting that feedback from the patients. All right.
Okay, so that was our, thanks, Maya. So we talked about communication, we talked about, using materials effectively. Our third strategy that we're going to review is the TeachBack method. If you haven't learned about TeachBack before, I encourage you to continue to learn more. It's a great method to increase patient comprehension and retention of information. And there's a lot of learning modules, YouTube, etc., that you can take a look at. So let's get into it. Why is TeachBack important? Studies have shown that 40 to 80% of medical information patients are told is forgotten, and nearly half of the information remembered is incorrect. So TeachBack is a way of checking a member's understanding, right, by asking them to explain back in their own words what they need to do, basically. It's a way to make sure you explain information well. So it's not a test or quiz of the patients, it's a reassurance that you want to make sure that you're communicating right. So we'll go into some more detail. Why is it important? It has been shown to improve patient understanding, adherence, decrease callbacks, canceled appointments, and improve patient satisfaction and outcomes. So TeachBack's a great method to use. Some of the elements for using it, these are things that go along with our communication skills, using a caring tone of voice, displaying comfortable body language, using plain language like we talked about, and of course, reader-friendly materials. So, our job as the provider is to provide the information and then ask the patient to explain back using their own words. Avoid asking questions that can just be answered with a simple yes or no. And we talk about open-ended questions when we go over motivational interviewing in a little bit. And then, of course, document your use in response to the teach back. So here's a quick visual aid. So you want to chunk and teach information. So a member comes in and they have, an asthma, diabetes, and high blood pressure. You're going to want to teach each section as a chunk, not all of it at once, which makes sense. It's easier to process. And then once you present the information, you ask the patient to teach back in their own words, use materials if you have them. If they are able to teach it back, then you've done your job and you can move on to the next part of your visit. If they aren't able to, then you kind of have to retweak what you say. You might reteach it using different words. And then, just continue to go forward until the member has that understanding. All right. So any questions before we get started? We're going to do a quick example of teach back. Okay. All right. So Maya and I will do an example. The next few slides will serve as a handout. So just imagine this is a handout that I'm going through with her. All right. All right, Mrs. Campbell, as you know, your COPD and diabetes put you at a higher risk for developing severe COVID-19. I'm going to prescribe you the antiviral medication called Paxlovid. This is what a dose of Paxlovid looks like. There's 2 pink pills and 1 white pill in each packet. You need to take the whole packet twice a day for 5 days. Here's some general information about taking Paxlovid. I've highlighted the most important instructions. And here is a list of medications that you cannot take when you're taking Paxlovid. Are you taking any of these medications currently?
Yeah, I do take St. John's wort daily.
Okay, so we'll want to make sure that you don't take your St. John wort while you're taking the Paxlovid for the 5 days. And here are some side effects to look out for. The most important thing is liver damage. If there's any symptoms like changing, your skin turns yellow, your eyes turn yellow, your urine's dark, or you have itchiness, call the office right away and let us know. Other side effects are common and I've circled them. If any of these do take place, they should resolve on their own within 3 to 5 days. So I'd like to make sure that I explained everything clearly to you. Can you please tell me, how are you going to take Paxlovid and what will you look for?
Okay, so each pill packet has 3 pills. I need to take 2 packets. I need to take 1 packet 2 times a day for 5 days and avoid taking my St. John's wort. And I can't remember what side effects to look out for.
Liver damage is the big thing.
Okay, yeah, that's right. So if I notice any changes to my eyes, or if my skin turns yellow, or if my urine gets dark, or my skin gets itchy, I'll be sure to give you a call.
All right, great. So that's our example. It's a quick example of teach back. Just presenting the material in plain language and easy to understand, and then asking her to just let me know what she heard. Any questions on teach back? All right, we'll get moving then. The 4th health literacy strategy is Small Steps to Health. It is a project that I worked on with the medical residents in training at Authority Health. We actually did health literacy in a laundromat at 7 Mile and Van Dyke. It was really cool. Every weekend we spent 2 hours and they would teach about different health education. That project was kind of put to the side for COVID, unfortunately, but we came up with another project called Small Steps to Health. And basically we had 5 major conditions, the usual, right? High blood pressure, diabetes, and then healthy eating, activity, and stress management. And so the whole point of the campaign that we were going to do at a different laundromat was the small step behavior change. And really just wanted to quickly review this. Again, you could learn a lot about this for a long time, but it's setting goals with your members and your patients. You know, sometimes we have a tendency to go by the guideline, right? I've seen it here. I've seen it in other places in charts where people will chart, you know, recommend 150 minutes of cardiovascular exercise a week. That's it. Or, you know, recommend 64 ounces of water a day. And of course, those are the recommendations, right? I mean, the American Heart Association says like 150 minutes a week. But when you present that, I mean, I know how I feel if a doctor told me that. I'd say, well, how do I even get started, right? Or that's just way too much. So we encourage you to work with your members and clients to create goals that are small and attainable. And that's what small step behavior change really is. So, you know, maybe you don't have time to go out and walk 30 minutes a day. But maybe you have 5 minutes that you can do like YouTube dance videos in the kitchen, you know, with your grandchildren or something like that. Maybe you can drink 1 glass of water every morning when you first wake up. That's something to, you know, kind of increase water consumption. So just wanted to throw that in there just to kind of give an example of goal setting. Maya, I would love if you would share your small step to behavior change for your goals.
Yeah, so I'm on a continuous, I don't want to call it a journey, but I'm on a continuous healthy lifestyle journey. I did lose 140 pounds. So one thing I did, I love Law and Order. After work, I love to decompress and watch Law and Order. So what I would do as kind of a way to make sure I'm staying active in the evenings when I come home after work, I would just walk in place for the whole 60-minute episode. While it's not jogging or running, or sometimes I would jog or, you know, maybe do some hand motions or some squats in there. But the goal was to be continuously moving for 60 minutes. And I know that it was 60 minutes because, again, I love Law and Order and their 60-minute episodes. So that was a small thing, but over a week or a month, that's a lot. That's, you know, 60 minutes daily of continuous cardio. So that was my small step.
Thank you, Maya, for sharing that. I love that you were able to do that. Does anyone else have any small step behavior change that they'd like to share? All right, if not, we'll go on to our last health literacy strategy. And I'll turn it back.
Thank you. So health literacy strategy number 5, consider language and culture. So very fortunate for us that work or live in Wayne County. Wayne County is a melting pot of many different cultures and different languages. So it's important to understand the population served or our population served. So we'll begin with a review of CLAS or CLAS. So CLAS or culturally and linguistically appropriate services. This is the framework to deliver healthcare services. It's respectful and responsive to the patient's cultural beliefs and preferences and communication needs, and this does promote health equity and reduce disparities. All right, so the CLAS themes, the principal standard, governance, leadership and workforce, communication and language, and engagement and continuous improvement and accountability. Okay, so some strategies to implement CLAS. These are some language-related strategies. Assess language preferences and language assistance needs. Use acceptable language assistance services and do not use unacceptable services. We'll get into that in the next slide. Plan for interpreter services in advance and provide written materials in the patient's preferred languages. So some culturally related strategies. Respectfully ask the patient about their health beliefs and customs. Don't assume. Avoid stereotyping based on religious or cultural background, and acknowledge and address any implicit bias. All right, so language translation services do's and don'ts. We do want to use bilingual clinicians or staff members whose proficiency has been confirmed, or staff who are trained as interpreters, on-site medical interpreters, or telephone or video interpreter services. We do not want to use clinicians or staff who are not trained or certified medical interpreters. And this is a big one that I did see a lot as my time in a clinical setting as a CHW. We do not want to use the patient's family and friends. This does pose a threat to, or I'm sorry, this does pose a problem to the patient's privacy, in HIPAA, and we respect choice and have quality interpreters present. Another big one, minors should never be used as interpreters. Okay. All right, so I'll pass it back over to you, Dr. Custer.
Thank you. And on that last note, Maya, you usually share, I'm going to share. You know, we know that a lot of times in our population, minors or family will be, you know, the only person. So we just, you know, we encourage that you respect the patient choice, but really have a backup interpreter. Okay, so written materials, I just want to bring this up. Care Guides, University of Michigan did a really good job. They spent a lot of time putting together this website. And basically it has materials for, these aren't the only conditions. It's really anything you can think of in various languages. And so they went ahead and they either gathered materials that are written at 5th to 6th grade level, or they've created them themselves. So the website's here, you will get the slides. And you can take a look at some of the stuff and see if there's something better than what you're currently using. MDHHS, of course, released a whole bunch of COVID vaccination flyers in multiple languages. So that is still available if that's something that would be helpful. And the link to that is at the bottom here as well. Okay, so language is one thing, culture is the other, right? So let's talk a little bit about cultural competence. Excuse me. So we know that religion, culture, beliefs, ethnic customs can influence how people understand health, how they make decisions about their health, how they take care of themselves. So cultural competence is really, it relies on the principles of trust, respect for diversity, equity, fairness, and social justice. A lot of the things that we've just discussed already during this session. As clinicians, you know, we need to consider culture and language in order to better engage our members in making treatment plans consistent with their values. So we talk a lot about, you know, person-centered medical planning or person-centered medical home. This is all part of that. That is partnering with the person before you to make shared decisions that are good for them and good for their health. So how can culture impact health engagement? We're just going to review a few different ways. Health beliefs. In some cultures, people believe that talking about a poor health outcome can cause it to occur. So if you're, you know, looking to talk about screening for different cancers and whatnot, that could present a problem. Health customs. In some cultures, family members play a large role in decision-making. It may be an elder or a group of elders. Ethnic customs, roles of women and men in society may determine who makes decisions about accepting and following through with treatments. So, you know, if the population has ethnic customs, something to consider. Religious beliefs, sometimes religious faith or spiritual beliefs affect how someone uses the healthcare system and the willingness to accept certain treatments or behaviors. Dietary customs, you know, this is a big thing because we always recommend the DASH diet. I feel like the DASH diet comes out every day, but you know, when we're prescribing or making recommendations about diet changes, we need to consider culture. We need to consider if the person before us has familiarity with how to cook the food that we're saying, right? So just keep that in the back of your mind that you may have a dietary difference, you know, and maybe additional training is needed. And then interpersonal customs, you know, eye contact may or may not be appropriate depending on who's sitting in front of you. Same for physical touch. So again, all of these examples are really to say that at the end of the day, we need to get to know our patient population very well so that we can make sure that we're being culturally sensitive. Addressing implicit bias. So the next few slides are going to go through some topics. We're just going to present them, kind of make some awareness around them. But again, I encourage you to follow up if this is the first time you're hearing some of these things. You could spend a whole semester just on this slide. So we'll go through them somewhat But bias is something we all have, whether we want to say we do or not. Everyone has been brought up in different families in different parts of the world, different cultures, different traditions. And, you know, our worldview, how we look at things is all dependent on what we grow up and learn and all that. So as a provider, it's important that we reflect, right? We look inside and we see, you know, do we have things or beliefs about certain types of people? Do we, you know, have stereotypes that we believe? Because these things can really impact our level of care that we are providing. Trauma-informed service. This is something that I bring up because it's really, really important, right? Has anyone ever seen this book or read the book, The Body Keeps the Score?
Yes.
Okay.
No, this is my first time hearing
Okay.
about it.
Okay, so I know any yes, that's good. I encourage everyone to read this book if you're able to. It is a little bit dense, but it's an amazing. Dr. Bessel van der Kolk does a great job explaining how trauma can impact our health. So, has anyone heard of toxic stress in this group, or how about adverse childhood experiences?
Yes,
Yes.
heard of that. And felt the toxic stress. I know how it feels.
So for those of us, hold on one second.
Have you read the book, Maya?
I actually ordered the book. I haven't started it, but we can definitely share it, Francella.
Okay, we can like have a book club or something.
Yes.
I like that idea. I apologize. There was someone at my door. So toxic stress, just to introduce it very quickly, you know that fight or flight feeling, right? We feel when we're stressed out, right? So that's our body getting ready to fight a bear, right? Or flee. That's a good level of stress. That's something positive to get us away from the bear. However, you know, when those levels in our hormones and specifically cortisol, you know, they get elevated, there's times that the body should have an opportunity to come back down and to get to ready to steady state, right? So we're not aroused so much anymore. We need to get back down to steady state. But if you have a situation where it's called toxic stress, meaning the stress is continually happening over and you don't get that chance to recover in between, those cortisol levels stay up in your body and they continue to stay up, and that can over time impact our health. And we've learned, you know, the adverse childhood experiences study came out in the mid-90s. And that was the first time that we really could see that people who had experienced certain traumas in childhood, you know, had a direct, I hate to be scientific, correlation with certain health outcomes. And so I bring this all up because in the context of cultural sensitivity, trauma-informed service falls right in there. A lot of the people that we serve have been through trauma, and we need to understand how that can impact health. So again, this is something we're just introducing, but I encourage you to follow up and get more information. Okay, so we now understand how trauma and toxic stress impacts. Okay, so let's talk about Maslow's hierarchy of needs. Maya, I am going to ask you to input, but you know, these are this pyramid shows, you know, the level of our needs, right? And these physiologic needs and safety needs, these are the most important things as humans that we need to survive, right? We need air, we need water, we need food and shelter. And I'm going to ask Maya to share, you know, her experience with someone who maybe is experiencing those needs.
Yeah, absolutely. So certainly after there's I feel like there's been this push for encouraging our patients and our population served to take care of their mental health. Certainly after COVID, there was a big push for mental health. However, during COVID and as well as now, there are many patients that are going through other things like facing eviction, loss of jobs, food insecurity. So it's great, and I am definitely a advocate for mental health, but it's difficult to talk about counseling with a single mom when she's facing an eviction. So that's just something to think about when we're working with our population served.
Thank you, Maya. Okay, this graphic comes from George Washington University, Dr. Dietz and his team. We just talked about adverse childhood experiences very briefly. I bring this up because the pair of ACEs shows that, you know, in order to make a difference and impact these adverse experiences, we need to really spend some time and talk about the adverse community environments, right? So this all boils together. We need systemic change, and we need it big time to improve our community environment and, you know, improve the quality of life for everyone. So I just wanted to bring this to you to kind of take a look at and think about as well. All right, we have one more slide and then we'll take a quick break. When I do this lecture with health professionals, graduate students, basically, I ask, this is our last slide before we break, so I'm going to ask you the same questions. So some questions to ask yourself, because at the end of the day, we want it to be a safe place, the person before you to be able to share, right? So have you considered the trauma this person has experienced? You can interchange trauma with culture or language. Have you considered the culture this person has experienced? Are you creating a safe place for the person to share? Do you have any unconscious or conscious bias to consider, or can you even be unbiased? You know, you have to be very real with yourself sometimes. How does your background, history, etc., impact your ability to serve the person before you? Are your actions making people uncomfortable? Are you using words that are respectful and culturally appropriate? And are you actively listening, or are you just talking or listening to talk? So these are all some of the things that we have to think about. I know this is getting kind of heavy, but when we talk about cultural competence in trauma-informed care. So I appreciate you all listening to Maya and I for the first half of the lecture. We'll go ahead and take a 5-minute break because we are running a little bit behind. We promise we'll finish up well in advance of time. Let's say we'll come back at 2:16. So everyone, we can do a 5-minute break. We'll see you in 5 minutes. Okay, welcome back.
I'll call him in.
All right, so can everyone hear me? Maya, we're good? Okay.
Yes.
Thank you. Okay, so we'll talk some about vaccine hesitancy. And I apologize in advance, some of these slides need to be updated. I already know that. So vaccine hesitancy, according to the World Health Organization, it's defined as a delay in acceptance or refusal of vaccines despite being available. And it is one of the top threats to global health, and there are few effective strategies. The causes of vaccine hesitancy are things that we've kind of already, been going through: healthcare inequalities and equities, lack of effective public health messaging, certainly a history of unethical research with certain minority groups. There's a lack of trust system-wide, social disadvantages, social determinants of health, the growing spread of dis and conspiracy information. Okay. And then barriers to access, which isn't so much of a problem here in the United States. We have vaccine. We're not going to go over the vaccine again. I know they just, this is old, the new recommendations for the booster is not what I have on this slide. And actually, the last time we taught, they were right in the middle of it. So I don't have the most up-to-date booster recommendations in this presentation. Does anyone want to come off if they know and share that?
There are 5 shots now, right? There's like a 5th one I know that's what I got Saturday, right?
Right.
So so you're talking about there's one beyond the 5th one? Is that what you're talking about?
No, they've just they released new indications for the vaccine.
Okay.
It depends on age. So
Yes. Go ahead.
Uh,
Jennifer.
Right now, what they are recommending is the bivalent shot as the primary. So depending on what age group, generally what it's going to be is 2 primary and then 1 booster at least 4 months over. And that's for the majority of ages. However, it does change age to age and what level of immunocompromised you are. I have not checked the specifics of the very young, but generally over 65, you get an extra booster. And with certain immunocompromised conditions and medication stuff, you will have an extended primary dose of 3 doses, but it is just the bivalent that is now recommended.
Awesome. Thank you for that information. So yes, the bivalent booster is the vaccination we're giving, and I will update this slide.
So to me, this is where it's got to be broken down a little bit more, because even though you said all what you just said, I'm not sure I understand where so I think that's an example, like it's a lot, and I've gotten the 5th shot, but this right here, I'm like, so did I get a shot too early? Or, I mean, I don't know. I feel like I don't even know what bivalent is,
Bivalent
or
means that it covers, so the monovalent means that it goes against one of the viral strains, the original one that originally was the COVID-19. Bivalent was that it goes against the original strain and the Omicron variants. So it goes against 2 viral compositions essentially. You should be good with your 5 right now. However, ACIP has not fully voted on the hard and fast recommendations, so they will still be updating. So I would keep in contact with your personal medical provider and up to date on news with what ACIP has been voting on. I do not know when they're voting.
okay.
Yep, and that's part of the issue with COVID. I mean, again, it's new, these recommendations have been coming out as we've been gathering data. It's not like we're, so it is a little tricky, and these recommendations are still changing, like Jennifer just mentioned. So it is tricky. I had 4, if it makes you feel any better, Pansel.
I just went and had the 5th one. Somebody said, why did you do that? Do you really need to do that? So this hesitancy conversation is going to be really interesting. I got a lot of questions about that. So.
Okay, yeah. Okay, so moving on, we're going to talk about 2 strategies, and we're probably just going to talk about one, and then we'll fly through the other one. But motivational interviewing is one of the best things that you can take away from this presentation. If nothing else, take some time to understand motivational interviewing after this session if you haven't before. This COVID-19 vaccination field guide is available at the end. There's a link, but they did put this out last summer, and there are some good strategies and tools to use. So if you'd like to look through that, you can. All right, Ms. Maya.
Okay, so motivational interviewing is a guided style of communication that balances good listening with giving advice. It's designed to increase the patient's motivation and likelihood of behavioral uptake. And it's based on a respectful and curious way of being with people that facilitates a natural process of change and while respecting the patient's autonomy. Okay. Okay, so just in the sake of time, we won't go through each block of this chart, but you will get a copy of the presentation so you can go back if you'd like. The spirit of motivational interviewing is a conversation or collaboration between the patient and the practitioner. The authoritative or the old school way of communicating is, I'm sorry, before I jump there, motivational interviewing is, I like to think of it as the understanding that the provider is the expert on the medical side and the patient or the member is the expert on their personal situation. While the old school or the authoritative way of practicing or communicating with patients is the doctor knows best. The doctor is the expert. What the doctor say goes. Okay.
Yep.
All right, so we can go on. So we want to talk about ORs. So open-ended questions and questions that cannot be answered with yes or no. So we'd use examples like, tell me more about, to start the conversation with the patient. So affirmations, recognizing and reinforcing the success, being sincere, that is a big one. That being sincere does help build the rapport and the trust with the patient. Reflections, mirror what the patient is saying. I know that we talked about that in a previous slide, listening to what the patient is saying and using the patient's own words. And summarize. So in the summary, it does help clear up any discrepancies or poor communication, and it's a good bridge to transition between topics. Okay.
Okay, so we'll do an example. Oh, I think you have a few more slides, but when we, hold on, I'm cutting her off. Never mind. Go ahead.
No, it's okay. Go ahead.
I was just going to say again, you know, the ORS. So ORS is one of the models of motivational interviewing, the most common, I feel like, that we learned. So it's just really important to know, you know, you're asking an open-ended question and then you're listening and you're reflective listening. And that's, you know, the gist of it. Go ahead.
Okay. So motivational interviewing strategies to discuss COVID. So one, you want to start with those open-ended questions. It's a soft start to a controversial topic. And two, acknowledge the patient's concerns without judging. Empathy reduces the perception that you approve or disapprove, and avoid criticizing the patient's information source. Cite your experience and point out and provide factual information. Many times that information source could be a religious leader, it could be a respected elder. So we don't want to criticize that, because that is a breakdown in the, you know, could potentially compromise the relationship between you and the patient. Okay, so continue. Show awareness of your status as a messenger. This is especially true for our communities of color. Who we are as a messenger is very important. So that is the fourth strategy. And five, link vaccine acceptance to the patient's hopes and goals. I can think really quickly about an example of this, a patient who really wanted to get back to spending time with her grandchildren. So we talked about how she could maintain her health status so that she could get back to spending time with her grandchildren. So that was linking what was important to her goals and her health. Okay.
Okay, so we're going to do an example of motivational interviewing. So we're going to do I'll be the doctor or the practitioner, and Maya will be the member. And we're going to do two examples. The first time we go through, we're going to do a traditional approach, right, that Maya just presented. So that's more of the doctor's knows best type scenario. And then we'll contrast that to a motivational interviewing approach. So let's go ahead and get started, Maya. All right, Ms. Campbell, it's important to immunize your child. If not, you're putting him in danger. Do you know there's still cases of measles? This disease could be very dangerous. And what about meningitis? It could be fatal, you know. You should update your child's vaccinations as he is already late according to schedule. We could do that now if you want.
I don't see the urgency, and autism is way worse than measles. There are more problems than solutions with this vaccine. Moreover, it's completely unreasonable to give so many vaccines at the same time.
Studies have demonstrated there is no link between autism and the measles vaccine. The vaccine is safe, I assure you. You should be aware of the information you find on the internet. Giving several vaccines at the same time is safe and not associated with more pain. We should update his vaccines now.
Well, I've heard something else, and not just from the internet. I do read a lot, and vaccines are not mandatory. I can do whatever I want.
Yes, you're right. It's not mandatory, but you're putting him and other children who cannot receive vaccines in danger. The risk of diseases are much higher than the risk of vaccines. If I'm taking this time to speak with you, it's because it's very important.
It's easy for you. Everything is quick. But what about autism? I'm worried about the risk of the vaccine, and you don't seem to be worried about the health of my child.
Of course I am. And I'm worried about the fact that he could get diseases that can be prevented by vaccines.
Yeah, I don't think that we're understanding each other. So let's just talk about this at another time.
Okay, so I adopted the role of the expert using a directive intervention approach. So I'm argumenting, I'm writing her in this led to an opposition, and she declined the vaccination. So now we're going to do another example using kind of a motivational interviewing approach instead. Okay, Ms. Campbell, what do you think about the advantages of vaccination?
Well, I know that vaccines protect children against diseases that we don't see anymore. My child received all of his first vaccines, but I'm worried about the measles vaccine, that it could cause autism. For other vaccines, I have fewer doubts, but for that specific vaccine, I'm still hesitating.
As you've said, vaccines have reduced diseases in such an important way that they're now much less frequent. It's why you vaccinated your child when he was a baby. If I understood you correctly, with the exception of measles vaccine, other vaccines seem safe to you?
Yes, I know it's a good thing to prevent those infections, but about measles, I'm conflicted. You know, I read a lot of books and articles, and lots of people are worried about the link between measles vaccine and autism.
Okay, so you find it's important to protect your child against disease when the vaccines are safe, but you are worried about what you've heard regarding autism and measles. I see that you've done a lot of research about the subject. If you agree, I could give you some additional information on studies on autism and measles.
Sure, I want to know exactly what's happening.
In fact, you're right. One study had hypothesized a link between vaccine and autism, but this study was fake and the author lost his medical license. More than 500 additional studies around the world have demonstrated there is no link between vaccine and autism. The frequency of autism is the same in the vaccinated group of children as in a non-vaccinated group. What do you think?
Well, so I'm not so crazy to be worried about this.
Of course not. You're totally right.
Okay, well, thank you for taking the time to understand my concerns, and I think it's a bit more clear now.
Okay, so in this example, motivational interviewing allowed the mother in a non-judgmental way to express her concerns and her ambivalence, and I was able to give her solicited information that she accepted. So it's a very, very, not subtle, actually, different way of communicating. And so we all, as providers engaging with community can learn this technique to really tease out the members' motivations, right? And what do they want to do? Why do they want to make the change? All right. So that was a quick example. Any questions about motivational interviewing?
So this is an example from a provider talking to a patient, right?
Mm-hmm.
So I would be interested in even knowing how, at a community level, how to have the conversation with people, because we face that. Even I approached a couple of people. I know we've been out canvassing, and people are just sort of, first of all, all the restrictions have been lifted. People feel they're free to go out. They don't think there's a threat anymore of the pandemic. And so people are not feeling the need to some of them haven't gotten the first shot still, which I was really surprised that people still hadn't even gotten shot one. And so so that would be interesting, just how to have that at a casual model of a conversation. So, because I know from a provider standpoint, I get it in terms of, the health literacy from that standpoint, but just the casual conversation, simpler way of having to react. And so I have some thoughts about what to do, but I just wanted to hear, like, what have you been experiencing or hearing from that perspective, from the community perspective or community health workers perspective?
Absolutely, Maya, please feel free to jump in. I think with motivational interviewing in general, it's just really about opening it up with an open-ended question and not judging, right? So just listening. But Maya, go ahead if you have any specific advice.
Yeah, that is very true. It is really just listening to what the patient or the member wants. And the hard fact of it is not everyone is going to get the vaccine. Not everyone's going to agree. But at least at the bare minimum, we're providing factual information.
Yeah.
Sorry, you talking to a screen. Sorry, I mean.
It's okay.
Good to see you.
A response. So, okay. I just have some thoughts, and I was actually private chatting Dewan. I know right at the very beginning, we actually did have like a webinar where there was no convincing. It was just people asking questions and we responded. There was no PowerPoint presentation. There was nothing, and I feel even that was, and it was, early on, the pandemic, we were just shutting down. I mean, it was like maybe a few months in, but I'm thinking now, just doing the same thing again at this stage is like just people coming and having questions. And they, and then we respond. It seemed like they got more out of it rather than us trying to convince, because there were a lot of convincing why you should get the vaccination, right? And we were saying, we're not going to convince you one way or the other. We wanted anyone who had any kind of, so I'm thinking that maybe doing it again, where we just once, and I was telling DeWan, we should have all the core leaders, actually be on this literacy, the full literacy, but then there's this other layer of having a conversation about it, because I think because the world has changed as a result of it, but it's a little different. So people think we're in the clear, but I don't know if that's necessarily true. So how do we kind of listen? So those are just things that are ringing in my head right now.
Yeah, those are all good things. And you brought up, I think you brought up a lot of really good points, Pansela, but we're at this place now where as a nation, we don't want to talk about COVID anymore. People are really over it. And it's not gone. And we'll talk about that.
No,
in just a second.
we're hearing people who are still, still being impacted by it adversely or badly, adversely or badly. And so we are still, but it's not as much as it was before.
Yeah, certainly the strain has changed. Now it's not killing as many people. It's less deadly, but it's more virulent now, so it spreads easier. Hard conversations. That's why we're doing this grant, Pansela. Seriously. Okay.
I know. I know, and the world is changing it's at this pivot moment to me. It's like it's a pivot here. And so how are we, that's the question. That's what I'm wrestling with.
Yeah, that's a good point. All right. If anyone else has, communication techniques that they want to share, anything, please jump in. Does anyone know the difference between, we're going to move on, misinformation and disinformation?
One is
Yes.
purposeful and one is just having the wrong information. But I can't remember which is which right now.
Yeah, I think a disinformation is intentional of getting the wrong information out there, and misinformation is just lack of understanding of what you're putting out there.
That's great. Yep. You're both right. Okay. So social media, I don't think I need to tell you this, but this is the social media landscape in 2022. The whole point of this slide is just to show you how many different sources of information just in social media that people can access. So, it's no wonder that there's a lot of different messaging going on. So some of the strategies for this. Maya talked about this a little bit with her motivational interviewing slides. Do not argue information. It's better to just provide factual, easy to understand, correct, accurate information, rather than trying to argue against someone's misinformation or disinformation. Using credible sources to demonstrate facts. Something that's come up through these trainings that I think is really interesting is, what do you do when the people you're talking to don't believe the sources are credible? So now we have people that don't believe the CDC is the best, thing for the health, et cetera, et cetera, et cetera. So it's an interesting, tricky time when we're talking about certain things. And again, like Maya said, if you can use trusted messengers, any community champions, there's always someone in the neighborhood that everyone knows, that's the trusted messenger. It can be faith-based, celebrity, etc. I do need to update this slide. These are actually data from November 2022. And I will update it for the next session, but this is just showing the hospitalization. So, we say, okay, we're going to provide factual information to combat, the disinformation. Well, the facts are, if you have been vaccinated, you're less likely to be hospitalized with COVID. And then we move on to deaths. And again, an older slide, but we're still seeing that if you've been vaccinated, if you haven't been vaccinated, you have a higher likelihood of dying from COVID-19. With the Omicron booster, that's what you see here. It's almost zero, so may convince people, it may not, but this is, what we can do is we can show them this and say, okay, these are what we've come up with, what we see. All right, so this is our last interactive slide. I'm going to turn it back over to Maya so we can talk a little bit about this.
Yeah, so can anyone share, or can anyone quickly share an experience where they had to combat mis or disinformation regarding the vaccine? How did you react? And what was your experience? Does anyone want to share? I can also share as well. I have kind of a funny story. I have a teenager, and during the height of COVID-19, she was convinced that we were in the zombie apocalypse and that the vaccine would turn us all into X-Men and we'd have all these extraordinary powers. These were things that she saw on TikTok. So it's difficult, again, considering the age, it's difficult as a parent to combat a TikTok video. So what I did, I just provided her factual information. I said, look, we don't see any X-Men in our community. I've taken the vaccine. I don't have any powers, unfortunately, but unfortunately. And I just let her figure, as time passed, some of those conspiracy theory videos became less and less popular on her For You page. And she ended up taking the vaccine with me. So again, just providing factual information and allowing her to come up with her conclusion on her own.
Thanks for sharing, Maya.
Yeah, I think that's that. I'm gonna say that's how I have a bunch of friends who were buying into those conspiracy videos, and I was joining in the conversation because I didn't know what this was, right? But it was someone they did an action on me on a Zoom call and told me I needed to get the vaccination and set up an appointment for me to get it by talking about the factual things, and they were, so it was a Zoom call, and we were just talking about it, and we were supposed to be working on it, and yeah. But I do think that it's still hard now. I mean, I talked to a couple of people, and I don't think I have all the facts in terms of why. All I tell them is, I don't know. Yeah, I don't know how. I just tell them what I experienced, that when I did get COVID, how I was afraid. I said, I'm glad I actually had the vaccine, because I don't know if it would have, it could have been more detrimental if I hadn't been vaccinated. So I don't know. This is really hard.
But that's a really good point, Pancella, because you are a community champion. You are a recognizable face in our community. So your experience is valuable. You, again, can't tell people what to do as it relates to their medical, choices, but you can share your experience. So I think that what you're doing is very powerful.
Thank you.
So I knew quite a few people who not necessarily mis or disinformation about the vaccine itself, but more misinformation about vaccine mandates and how they would work, especially with work, and kind of like having like this like political charge to the idea that like some places would make you get a vaccine, and that it was being forced and destroying bodily autonomy, whereas like in most situations people were not required to get it, despite the fact that like the information kept going out that, oh no, everyone has to get it or else you can't interact with society. And that was that was a weird one for me. Because obviously you could see that people weren't really getting fired at like the scale that the mis and disinformation was coming out at.
Mm. Very good point.
Yeah, that's happening
Oh.
in family members. They're still, yeah, hanging to.
That's
I
really where I've seen it too.
I would say for me, early on, my experience was just friends who claimed to be completely anti-vax. And I don't know if my strategy was the appropriate one, but it was just reminding them how many vaccinations they already had just to complete school. And then, we had the government conspiracy people, and I end the conversation at that point.
Mhm. Mhm. That is so true too. And I think we used, I mean, I remember talking to a lot of people that wanted an exemption for school or whatnot, to get the vaccine and they were not able to get the exemption if they had already received all the other vaccines, right? So that is an interesting point. All right, very good good sharing. Yeah, thank you for sharing. All right, let's see. So we're not gonna review a case because we don't have time. So I'm gonna go ahead and pass it back over to Maya to get us kind of wrapped up.
Yeah, so great conversation. I always say I love each and every one of these trainings. We always hear different perspectives. So I'm so grateful that everyone is on the call today. So in summary, or our key takeaways, low health literacy is associated with lower health knowledge, poor medication adherence, increased use of ERs for primary care, and increased mortality rates, all of which impact the quality of life. And all of these are impacts of low health literacy. It is important to use, again, those universal precautions and assume that all patients have low health literacy. Improving individual and community health literacy levels can reduce vaccine hesitancy and increase COVID-19 vaccination rates. The final review. So it is recommended, the recommended grade level for all written materials is 5th and 6th grade. Health literacy strategies can be used to increase the patient's understanding about their health condition, empower them to take an active role in their healthcare, and some of the strategies that we discussed: clear communication, teach back, using linguistically and culturally appropriate materials, motivational interviewing, and combating misinformation. Okay.
Excuse me. So thank you for participating today. Our contact information is here. After we finish, I will send everyone an email with the link to today's recording if you wanted to watch it again or share it, as well as the slides. We'll come right back to this slide. CDC does have a health literacy training that's pretty comprehensive. So if you're interested, you can look on this site. And then again, I just wanted to show you the resources. That's the end of the slideshow. So if you wanted to look up anything we used. So thank you again. We'll end on our evaluation slide. If you are available and can participate, we encourage you to. You'll notice in the post-session evaluation, if you do it, that there is a section at the end that asks for your information. This is if you would like to receive a certificate for coming to today's session, as well as some CEUs from Wayne County Community College District. They require the information that's being asked, like your name, address, etc. All of that information is required for them to create a continuing education account for you to administer, to provide those certificates. The information is not, sold or given to anyone. So if you would be interested in that, please go ahead and fill out the complete post-session evaluation. I think Maya also put a link in the chat box. And if you're joining us online, the link should be below the module. All right, so thanks again, everyone. I'm going to go ahead and stop recording.